Sorry. Yes, thank you for the invitation here to Belgrade. I'm very happy to share with you our experience with the Tiger Retriever. Maybe you heard of that device. These are some disclosures. And the basic idea from that device came from another device that is called the Comaneci. Maybe you heard of this. This is a little bit like a metallic balloon, like a mesh that can be placed above the orifice of an aneurysm and act quite like a balloon, with the difference that there is no flow arrest in the parent artery while you coil the aneurysm. And this idea made the company, this is our experience with this. This is an example of an aneurysm treated with Comaneci, broad-based young lady. We wanted to keep her away from dual antiplatelet therapy. And the big advantage is that there is no flow arrest in the carotid while you keep the Comaneci up. You can close several times to check if there is an entanglement between the coil loops and the net itself, which is a catastrophe, of course, because we pull it out again. But the net is very good visible, so we didn't experience this, but I heard there were cases like this, and this is the result. So that's just as an introduction. So, and then the company had the idea to use that technology for stroke treatment as well, and the difference between these two devices is not much. It is that in Comaneci, these struts are not connected to each other, because this guarantees the capability to build like a shelf inside the aneurysm, which is not needed in a stroke treating device like the Tiger Retriever. And there is a wire fixed to the distal end of the device, and then there is this control handle, which in the very beginning was just a slider, which made it a little bit difficult, but now it's a stepwise operating device. And you can open the device and expand as much as you want and adapt, so like the radial force towards the vessel wall and the thrombus, which makes it a unique idea for treatment of stroke. And so that's how it works. In the meantime, there is quite a family of Tiger Retriever devices. It began with 21 and 17. This was our initial experience that we published already. And then there is Tiger XL, which is a very long one, which is mainly intended for the treatment of carotid T occlusions. And then there is what we heard a lot of today, Tiger 13, which is for distal occlusions. You can manage to treat M3s or even M4s with that device. I will show some examples of that. And of course, there is not a fixed rule which device to use and what occlusion, but as said, the XL is good for T occlusions. 21 can be used for nearly every occlusion up to M2. That was what we were doing in the beginning. 17 can be used in pericallosal occlusions as well, as my experience, but Tiger 13, as said, is the one for distal occlusions. And this is our setup. Of course, there can be other catheters used. What is important that you can use Tiger 13 with headway duo, so very long. It is long enough to reach these distal occlusions. And you can go nearly everywhere with that catheter. You know this from AVM treatment or things like that, which is the main advantage of this. And the treatment steps do not really differ from what you know from thrombectomy with self-expanding devices. There are maybe some differences to point out. In the beginning, you need to learn a little bit, which was at least my experience, that the device doesn't stabilize inside the artery by itself, which a regular stent retriever does. So you have to keep in mind or to be aware of the fact that the whole thing might come down a little bit. So you have to push when you pull back the microcatheter, push a device. Then you need to open the device, of course, according to a roadmap. I do this with a roadmap to know how much expansion is needed or is necessary. And then there is a question of how much to go down. There are several advices. Of course, there is a learning curve. René Chapeau said just go 6 up and 3 down, and that's all. Maybe a roadmap is helpful to see movement of the device. I give an example for this. And then last point, what I think is not that important, is that you can't pull out the microcatheter to enhance aspiration, because there is that control handle at the end. But I don't do this in all of the other cases. This is our experience with XL mini-series, and it is a very long one, and there is a trend towards longer stent retrievers, and we all know that in carotid occlusions the clot burden is quite higher. And these are our results. As said, mini-series, but good recanalization results, 2 hemorrhages, and in the meantime, that became too standard for us in T-occlusions. This is an example, the posterior arising from the carotid and then T-occlusion. Placement of the device, slightly opened, and then pull back the device with aspiration. In these cases, I try to advance with the aspiration catheter towards the tiger and then pull it in. And regarding 21 and 17, which were the first versions of the device, the most important study is the Tiger trial from the US, and that showed a quite good recanalization rate, slightly higher than known from other stent retrievers, with a 60% good clinical outcome at 90 days. And these were one of our first cases, typical M1 occlusion, then placement of the, I think this was a 21 in this case, a little bit distal towards the thrombus, or at least 2/3 behind the thrombus, is my experience, is good with that device. And then you have this curved shape of the tiger once expanded. And this is the moment where I go down a little bit with the expansion to straighten it a little bit, to not have this banana-like shape and pull it out like this, because this could put harm to the vessel. So always be aware to go down a little bit with the expansion while retrieving the device, which is different with what you know from self-expandable stent retrievers. This is some kind of like a double occlusion, M1 and A1. I started with the M1, Tiger 17. Here you can nicely see the expansion of the device, and you can also go a little bit up and down with the device while it is inside the thrombus, which the company calls the Tiger Flex technique or massage technique, and they did laboratory testing and could show that this is more effective. I don't do this in every of these cases, and I don't do this in far distal cases, but it might help probably. And then pull out the tiger and open the MCA, and then you can use the same device for the A1 occlusion. Place it here just a little bit inside the origin of the ACA and then pull that out, and this was good in the end. So nice technique. This is our experience with the first version of the device. So this is only 21 and 17, and there were 3 groups resulting. One is tiger first, so intention to treat with tiger. And then there's the group with those where the procedure was finalized with the tiger only. And then there is the bailout group where other devices were used, so where tiger failed. And then there is the group of other devices first, the tiger is bailout. And you can see the results in the tiger only group are very good. Of course, there is a selection bias because these bailout cases are probably the most challenging or the more challenging ones. So we had 70 cases done. These were the locations, mainly M1 and ICA, according to the initial version of the device, so not so many distal cases. This is the tiger-only group, and you can see there's nearly 100% 2B and higher in that group. Maybe selection bias, first cases, easy cases, but good results. And this is what we did with a colleague nearby, Hannes Nordmeyer. We collected our cases, Tiger 13, so the small one. And we excluded M2. Maybe you know this discussion, the smaller M2 branch is distal or not. So we excluded this. This is different in other studies. So if you compare these studies, always be aware of M2. Some have 90% M2 occlusions. I don't know if this is really distal, but these were 45 cases with good TK2B and 3 results, and we discussed this in the beginning of the session. Of course, the rate of SIH is higher in that group, and this was 14, and I remember a paper from Chapeau where this was even higher than that, which is probably because they had more distal located aneurysms. But the question is, are these symptomatic hemorrhages? And these are not in the majority of cases, because this is perform regular CT on the next day, and so someone said, this is just a little white on CT, this is not a symptomatic hemorrhage. So we had no symptomatic hemorrhages in that group, but 14% of hemorrhages seen. This is an example. As Mario said, we also do perfusion imaging in these cases. This is the patient. You can see the ischemic lesion there on the left side. Perfusion showed a mismatch, and there was relevant clinical symptoms of the patient. That's why we decided to go for mechanical thrombectomy. Here you can see the distal occlusion. And okay, this is, you can consider to do nothing in that situation, but makes no sense if we did in angiography. We can do adapt alone with an aspiration catheter, but sometimes I think in that curved anatomies it's not so easy to get to these lesions within 3 max, for example. If you're there, it is easy, it is good, but sometimes it's even difficult to go there, which is not with Headway Duo. No problem to pass the occlusion and then place the tiger. This is the video. And in these distal occlusions, I always go down a little bit with the expansion to lower the risk of hemorrhage or vessel damage, and then pull this out. I do this without adapt, different to what was said before. We can discuss this maybe, but I don't advance with any other aspiration catheter. And this is the result, and this is the thrombus caught in the struts of the device, which you not always see. Sometimes the thrombus is in the aspiration, but in those distal cases, you can find this inside the mesh, and that is the final angiogram, TK3, and this is the discharge, or the CT on discharge with no change of the ischemic lesion.
But technically, let's say it's the distal occlusion and the device is small, so you put it right at the side of the thrombus.
A little bit behind it.
A little bit behind, okay. And then
2/3 behind, so it's just my experience. It's not.
And you do the massage?
I don't do this in these distal lesions because I think this might enhance the risk of damage, but the company did testings and so a lot of operators do so.
Okay, and then how many clicks, sorry, you go up and...
So normally, this is on the next slide, I do a roadmap, and then I go down, and if the device goes, if I go up and expand, and it goes out of the roadmap, I stop with the expansion, and when I retrieve, I go down to get it, let's say, to the roadmap again, and then I pull it out.
Do you do proximal pinching with the microcatheter?
I don't do in the distal cases. I just leave it as it is, open, close. I wait some time, like 2 minutes, leave it open, and then just pull it out.
And aspiration is down there? Catheter, yeah?
Aspiration from the carotid or M1. My experience, I had a case where I did like anchoring, and the Tiger 13 was up somewhere in M3 or something. And then I did anchoring with, I think it was Sophia 5. And that was not a good idea because, as said before by Marius or Mark, I don't know, there was this movement of these distal vessels that are quite movable, and I had a serious hemorrhage. So this made me stop this. And in the majority of cases of distal, I think it works without aspiration, but maybe with more flexible, smaller aspiration catheters, there is no problem, but I see no reason to advance in an A1 with the Tiger up in the pericallosal artery. I think this might be dangerous.
We do with the distal, we place the Sophia 5 as much distal as we can, because I saw in our experience when we did without the distal that by pulling we were creating much more SH. So with that right, yeah. I bring the Sophia to reduce the friction as much as I can. And that is our experience.
And you bring it up to the Tiger
as much as I can.
And then you aspirate?
Aspirate constantly while I'm pulling back.
It is coming from anatomy, because when you reach the insular segment, that insular segment have a short the penetrating artery arising from that segment, and that is much more dangerous than M1. That's why it is better to not to stretch that part, and that's the idea to move forward with the aspiration catheter coming from that one. And also the anterior cerebral artery, it is better not to stretch the anterior communicating artery region because of the Höbner and other hypothalamic and other perforators. It is better not to change their location too much. That's why it is a good technique to move the distal axis catheter without changing the anatomy too much. When you pull back the microcatheter, whatever it is, Tiger or other stent, without moving too much on that location. I totally agree with you. So.
But to use, we mainly use Sophia. If we use some other distal access catheters, they are more rigid. So if you use other brands, then you are, as Nachi said, then you are changing the anatomy, and they are more stiffer, so they dislodge the whole vessel.
Exactly. Yeah, that is a kind of a balance, what we have in our hand, you know. Now we are getting a better technology, and we are actually searching for the more distal thrombectomy. And it is a balance.
So I would say if it follows easily, like to the A1, which is not always easy, why not? If you have to pull and go back and try to get the angle, I would avoid this.
Yeah,
I
exactly.
totally agree what you say, keep the anatomy, but 3 attempts trying to get the catheter up, if it, as you said, Sophia is good, but we all these other stiff things, I don't do
Yeah,
this.
because sorry to interrupt you, because when you see with those example new red catheters, the braid, the distal part of the shaft is very sharp. So
Yeah.
when you hook the A1 origin, then you with the inner curve you are entering, but with the outer curve you are hooking the A1. So if you have stiff, you can do a dissection and create more damage.
We learn it from ABM embolization. And then because you are stuck in an ABM, when you stretch the MCA vessel, look at that. After transarterial embolization, subarachnoid hemorrhage is more than 10%. And then everyone is saying, okay, majority of them disappearing without cunnicular. But it is because of that, the same arteries, the stretch, the same mentality. Either the stuck microcatheter in the nidus or the stent retriever with the thrombosis. The same mentality.
But I don't have much experience with Tiger 13, but maybe the part of the solution here is, as you already mentioned, you close at least partially the system, and then you don't have as much friction. And
I think that's true. I absolutely agree. But
the open stent retriever.
But if we do an M2 with a regular stent retriever, we sometimes really see M1 really going down on the road, which is not regularly seen with Tiger 13 because it's really a soft thing. It's not like a catheter with onyx and you have to pull and things like that.
But the problem is when you pull back, all the forces need to be transmitted to the distal. For that transmission, you need to elongate, you need to shorten the M1 segment. That is the transmission of the power, because the only thing what you are doing is pulling back. That's why the catheter technology and enforced technology is very important. We are focusing on the nitinol things or the fixed thing in the stent. Actually, it is the transmission of the power starting from the groin to the distal. That is the problem. If you don't transmit, you need to stretch it. That's very simple. The pullback doesn't follow, the vessel doesn't follow the order, by the way.
But in your hands, so you keep the cutter down and then you pull all the way. And do you lose in some occasions? Do you lose the fragment, or does it happen?
Probably I do sometimes, but
not that much.
Not much.
Okay.
So in other words, if it advances spontaneously to the M1 or to the A1, why not?
Let it go.
If I am in the M4 somewhere far away, I personally think that the risk of trying to advance everything to M1 might maybe be a little bit higher than pulling that very soft thing out of the arteries. But I agree what you said, that's true.
Yeah.
Of course, you transmit the forces to all these curved things. I agree. And do you think that when you advance with the aspiration and do aspiration, the vessel might collapse, and then when you pull back the tiger, the probability of dissection injuries might be higher? Heard of this?
No, my aim is not to aspirate this distal vessel. My aim is
You don't aspirate, you just leave it there.
Eliminate the curve by using the Guyane catheter.
So you
Because the
do,
distal
you don't do aspiration.
Can create the side dissection also.
Yeah.
And also less effective, the away
Yeah.
the thrombosis with the distal access catheter. My aim is not to aspirate perfectly well, just to cover the curve, eliminate the stretching a little bit more. That's it. But I know all the teams, especially the web user, are at the very beginning, first generation. And all the stroke guys. I'm really confused. I don't agree with them. Putting a large bore catheter in very distally without any fear. Without any fear. And they're having additional complication without checking the dissection, which is created by this material. And that's why I'm not a good guy to put the discussion on the stroke forum. And I can really discuss about it. What you are discussing in that manner, totally unacceptable for an AVM treatment strategy. Unacceptable. But this is the reality. We should accept that the technology in our hands now is helping us a lot. And the tiger mentality, I like it. And then the whole this concept is actually easy to use. Even the headway duo can accept a stent retriever. It is fantastic. The headway duo is one of the tiniest catheter we have after marathon. And that is amazing, you know. You can reach that vessel. I can discuss with
definitely.
you, is it necessary or not, but technically it is really amazing.
Okay, that case was
Sorry for interrupting. Huh?
no problem, no problem. So you see, it's in the A1, but not more, and or a little bit more, and this was good. So we had this discussion now when to stop the expansion. I do this roadmap. I explained to you how much to close, avoid the banana shape. I think this is good. Better go a little bit more down than put harm to the vessel. Additional contact aspiration. I think we had that discussion. I don't do in 13 regularly, but we discussed a lot on this now. Massage or tiger flex, I would say, why not? I don't do this in all of the cases, and this is a final example for maybe a situation where the tiger might be really helpful with its possibility to enhance the expansion. Very hard clot, several attempts with, I don't know, different standard stent retrievers that didn't work, and then tiger, I think 17 placed behind the thrombus and then pulled that out, and here you can see that very hard clot caught in the struts of the device. So as a bailout option, I think it is good because you can massage and you can enhance the radial force. So in summary, I think it's a good concept. We discussed this. 13 is a good concept for distal occlusion. It works, whether with or without direct aspiration or catheter. And yeah, this is our experience with that. And this is my hometown at night. Thank you.
I want to add from my from our experience, Tiger is also good to extract other devices.
Yeah.
So we managed to pull out some Atlas stents from M2, M1, M2. So when you entangle in those other devices, you can create a force necessary to pull it out. So. Last week we managed to. We had a complication. We tried to place a web, and web broke on the connecting the pusher, and it was lodged into the distal ICA. And I tried to snare it. I could not. I managed to pass with the Tiger XL. I managed to hook the web and pull it down, but it jumped on the curve. So.
Thank you very much for a great lecture.